Okay. Our last speaker before lunch is Dr. Daisy Robinton. Daisy Robinton is the co-founder and CEO of Oviva Therapeutics, and she has spent her career driven by the notion that healthcare can and should do more to empower people, especially women, to advocate for their own health. Given the historic gender disparities in biomedical research and healthcare, she launched Oviva Therapeutics with the vision to help women lead longer, healthier lives through the study of ovarian physiology and development of therapeutics to support ovarian function. As an authority on aging, Dr. Robinton has appeared in numerous publications, given a widely watched TEDx talk, and has been recognized by Forbes as one of their 30 under 30s for her scientific discoveries. Her writing has been published in periodicals such as Fast Company, Opera Daily, Nature, Vanity Fair, and Proto-Life. Dr. Robinton graduated from UCLA and completed her PhD in Human Biology and Translational Medicine at Harvard University. Please help me welcome Dr. Robinton.
Hello, everybody. It's such a pleasure to see you. It's such a pleasure to be here. Thank you to the organizers for inviting me. Before I launch into my talk, I wasn't here yesterday, but I was just thinking about how I got into this space. I'm not a reproductive endocrinologist. My background isn't in women's health. Of course, I am a woman. But I did my PhD in human biology. I'm a molecular biologist by training. And I came into this space when I was in my early 30s. I'd gone through a breakup. I went to see a reproductive endocrinologist as a means to understand my own fertility so I could chart a path that made sense for me. And I thought that I was very informed. I thought I was a very powerful woman. And I was very humbled by this meeting in the doctor's office by how little I knew about basic information about my own health and well-being that would allow me to make informed choices about my health, despite having a PhD in human biology from Harvard University, and despite being someone who feels very informed and very much an advocate for my own health. So my foray into this particular career path and into starting Oviva really was formed by that experience and by, as I sort of pulled the thread on that and understood more about the women's health space, just what a wide field of opportunity there was there. But in addition to that, the fact that having been in the aging and longevity space for a long time and attending many meetings like this, I didn't hear many conversations talking about the ovaries or talking about the importance of our hormonal health and homeostasis, especially for females, for extending our health span or preserving our health span or for being even related to our health span and longevity. And I still think that's missing in a lot of these conversations in a lot of these rooms. So I'm thrilled to be here to contribute to that conversation. Of course, we had Jennifer earlier, who always does such a fabulous job really painting that landscape. And I'll skip over things she already covered, but I'll build upon some of what she covered and share how we're really approaching this at Oviva. But I wanted to take a moment of time to really just introduce that, because before starting Oviva, I was doing a lot of this and coming to a lot of these meetings and really doing that with the lens of an academic scientist. And it's been sort of slow trying to turn the ship in this direction, but I think we're getting a lot of energy and enthusiasm for it. And as Jennifer said, more dollars, which is really what we need to do to move the ship. And we'll see where that takes us in the next 5 to 10 years. So really, to set the stage, to build upon what Jennifer already shared, we really know increasingly that there's been this historic inequity as it comes to the sexes when we think about biomedical research as well as clinical development. And I won't belabor this, I know it's a bit of a text-heavy slide, but I think the main points are that we know we focused most of biomedical research in male animals for the sake of simplicity and clean data. I'll also just note that there are studies showing that the hormonal fluctuations in male animals are quite variable and happen on a daily pattern, which could muddy up your results too, guys. Just saying. And then we know that it wasn't until the early 90s that it was mandated that women be included in clinical trials. So this has meant that many women get longer time to diagnoses that are incorrect, diagnoses that are psychiatric for physical symptoms. And most of the drugs that are taken off the market for adverse events disproportionately negatively impact women. So these are all things that we really aim to correct, and just sort of on a broader cultural and environmental scale we want to change. But at the bottom of this is the fact that female reproductive physiology, fertility, for example, these are robust markers of vitality and of well-being, and these have been grossly overlooked for the vast majority of time. And so if we can tune into this as a marker of our healthiness, of our well-being, of our health span and longevity, I think we'll be one step closer to having a better approach, especially for women in particular, to drive healthy outcomes. Now, Oviva Therapeutics, our company, was founded with a mission to correct this historic inequity. And we've really taken the lens that our ovaries are the seat of health and well-being in women. As a means to address this, we are looking to extend ovarian function by intervening on the ovarian reserve, and I'll explain that in a few slides. And in doing so, we're targeting the anti-Müllerian hormone axis to preserve ovarian reserve, extend function of the ovaries, and in doing so, extend health span in women. Now, why we're interested in this is because we know that of the major organs that age at varying rates, as we've heard earlier today, the ovaries are aging roughly 2.5 times faster than the rest of the body. And not only that, but they undergo this precipitous decline. I realize I don't have a laser pointer. And this one isn't quite working. I'll gesture. We have this precipitous decline that the ovaries experience between roughly ages 35 and 50 for women. And what this means in part is because you have that short time frame this happens under, and because hormones are so important for our overall health and well-being, is we see these very erratic symptomology for most women as that rapid decline occurs, rather than the gradual decline that we see for most of the other major organs in the body. And we know that this puts women at a distinct disadvantage for a variety of reasons. I know Steve Horvath is speaking, I think tomorrow, I forget when it is, but this first line is data out of his lab that shows that hormonal changes associated with menopause actually accelerate cellular aging in the rest of the body by roughly 6%. Not only that, we know that ovaries, or the decline of our ovaries and the onset of menopause is also associated with a significantly increased risk of cardiovascular disease, increased risks of osteoporosis, sleep dysfunction, immune dysfunction, sexual dysfunction, changes to hair and skin that are generally not positive, not to mention the dysregulated glucose metabolism that many women experience. So on the whole, there's a lot of disruption that happens systemically for women, and what this also means is that women are experiencing a much lower quality of life as they approach menopause and then afterward. Now, I do think it's worth mentioning here because obviously menopause has become more of a topic of conversation in the United States in the last, 12 to 18 months maybe. And there's an emerging narrative about how it's really empowering for women, and they're at this new chapter where they can really claim sort of the wisdom that age brings them. And I want to say that I don't think menopause itself should be the enemy. I think that what you're looking at on the screen here, this constellation of negative health impacts of the decline of our ovaries, is really the problem. It's not menopause itself, which actually many people don't know is a single day. That's 12 days, 12 months from the date of your last period. Anything before that's premenopausal, anything after that is postmenopausal. So menopause is your one day, fun fact for the room. And it's not menopause that's the enemy, it's that we have negative health outcomes that accompany that we're trying to address here. So interestingly, we also know that ovarian health and function is linked to longevity. So women who go through menopause later tend to have longer lifespans, and those who go through menopause earlier tend to have shorter lifespans. Now, interestingly, this has also been somewhat recapitulated in, there we go, in an experimental model in rodents wherein young ovaries were taken out of young animals, transplanted into older animals, and this allowed for lifespan extension in those older animals by 6 to 11%, with the relative extension of lifespan directly proportional to the relative youth of the ovaries transplanted. So this evidence supports the notion that the health and function of our ovaries is inherently linked not only to our longevity, but also our well-being. Now, assuming that most of us in the room aren't experts in ovarian physiology or reproductive health, I'll do a quick primer on the ovaries as a structure, which will help you understand better how we're approaching this mechanistically and therapeutically. On the left-hand side of the screen here, you can see the ovary. It's that egg-shaped organ. It's about the size of a walnut in your average size female. And within the ovary, we have what's called the ovarian reserve, depicted here in orange dots, which are actually representing a structure called the follicle. The follicle is a cyst. It's a fluid-filled sac, and within each follicle is a single egg. And the function of the follicle is really to house and support that egg, to help it mature as it moves through folliculogenesis during a woman's reproductive menstrual cycle, at the end of which there's usually one dominant ovulatory follicle which releases the egg for potential fertilization. Now, the follicles within the ovary are really the fundamental unit that underlie ovarian function, and that's because they're responsible for the production of most of the hormones that we're familiar with in the ovaries that drive the homeostasis in the rest of our body, as well as the process that you see here on the screen. And we're really born with this endowment of follicles, or eggs, and this represents our ovarian reserve, which, interestingly, we have a peak of in utero. So the most eggs that we have at any given point in time happens at roughly 20 weeks gestation in our mother's womb. By the time we hit birth, that number drops to about 1 million. And then we undergo a huge amount of attrition between there and puberty. About 300 to 500,000 eggs are then left once we enter the phase of our life where we're deploying those eggs for their use of being fertilized. And this part of the graph here between puberty and menopause is really where we are most interested in at Oviva, the pace of attrition of the ovarian reserve over time during a woman's reproductive years. Now, in that time frame, the main hormone, the master hormone that's controlling the pace of attrition of the ovarian reserve, is a naturally occurring hormone called anti-Müllerian hormone. It's produced and secreted by the ovarian granulosa cells and these sort of early maturing follicles in this folliculogenesis path, and it acts in a suppressive mechanism on that very first step in folliculogenesis that you see there. It's essentially a brake, and it can control, based on the level of AMH, it can control the number of eggs that depart the ovarian reserve in any given cycle. So a nice way to visualize this, wrong way, is if you have extremely low levels of AMH, which you can see on the bottom of the screen here, you don't have enough of a brake on this first step, which means that you have a greater than typical number of follicles that leave the ovarian reserve and enter that maturation pathway, and your ovarian reserve is depleting faster. This can occur in women who are patients undergoing chemotherapy, for example. That chemo treatment will damage the structures in folliculogenesis that are producing AMH, which means you'll either lower or completely eradicate endogenous AMH, and you lose that suppressive mechanism. This is why many women who undergo chemotherapy or radiation treatment will go into menopause after that treatment, because they lose the regulator of their ovarian reserve. In contrast, there are some people who have high AMH levels. This can happen in women with PCOS, for example. And when you have high AMH, you have a smaller number of eggs that are leaving the ovarian reserve and going through that maturation pathway over time. So the therapeutic that we're developing at Oviva is a recombinant form of this naturally occurring hormone. Now, this is no easy feat. There have been many people who've tried to do this in the past and failed. And I'll speak a little bit about the molecule and tell you why that is. So I mentioned already it's produced and secreted by those ovarian granulosa cells, and it comes out as this dimer, these two pieces here, pro-AMH. But in order for it to become active, that has to be cut. And the remaining 4 pieces, which you can see in pink and orange here, must remain in non-covalent association with each other in order to recruit and bind to their dedicated receptor and initiate the downstream signaling. So there's a number of processing steps that must occur in order for it to be the right shaped protein, and it's also quite large. And this has really limited translation around this hormone, really making it one of the last women standing, so to speak, in terms of reproductive hormones that have seen translation. Obviously, we know there's oral contraceptives, there's drugs that are used for IVF, there's hormone replacement therapy. Nobody has developed AMH as a therapeutic to date. Now, our scientific co-founder, David Pepin, and Pat Donahoe, our other scientific co-founder, have really moved the field forward in a significant way by introducing engineering that allows for not only the production of this, but also the purification of this protein at a scale that's reasonable for translation. And that's the IP that we're moving forward with within Oviva to translate this. In the long-term vision of introducing a recombinant AMH treatment that allows us to change the pace of loss of the ovarian reserve over time and hopefully forestall menopause and the consequences of menopause. Now, in terms of that translation, this is a very conserved pathway among mammals, and there's also some really interesting data within humans that suggests that it would translate well for this setting. We know low AMH levels correlate to poor fertility outcomes. We know they're also predictive of earlier onset of menopause, as well as increased risk of early onset vasomotor symptoms. Whereas high AMH levels, for example, women with PCOS, who I mentioned earlier, correspond to increased oocyte capture from ovarian hyperstimulation. So if you're going through an IVF cycle and you have PCOS, you tend to get better outcomes. This is also the primary indication that we're going into in clinic, which I'll talk about in a moment. So this really bodes well for that strategy and also for the fact that AMH really is important not only in modulating ovarian reserve, but also fertility outcomes and menopause. Now, as one of the only therapeutic biotech companies in the women's health space, there is quite a long journey ahead, in large part because there's such a dearth of data that's been persistent for so many years. But that being said, we have charted out what I think is a really thoughtful and rigorous, meaningful path to get us to that long-term goal. As you can see, our little blue hair runner who's reducing her mortality with her daily runs is here on the journey. We've done a lot of the important validation from the chemistry and manufacturing standpoint with some primate work that we've done, some preclinical work that we've done, and this is carrying us into clinic for this population of women that have a high unmet need around poor responders to in vitro fertilization. And I'll talk about that in a little bit more detail on the next slide. But ultimately, what we need to do beyond that is continue to build the data to show that this is not only safe but effective for women taking this over a longer period of time, ultimately with that long-term goal of having it be offered as a chronic prophylactic to prevent ovarian decline. Now, that first step is really to establish proof of concept in a more short-term indication where we can really demonstrate clear endpoints and efficacy and, of course, safety in a patient population that does have high unmet need. And so I mentioned already that in this case, we're looking to women who are poor responders to ovarian hyperstimulation, or IVF, as it's more commonly known. So what we're looking at on the screen here, and we don't really need to go into the details other than to say that this is a standard stimulation protocol for women undergoing IVF, people who are seeking to harvest eggs, potentially to fertilize and implant, or maybe just to put on ice. So women who are poor responders will frequently retrieve fewer than 3 oocytes. And for anyone who might be familiar with this space, you know there are 2 key drivers to success in IVF. The first is egg quality. That's largely dictated by your age and genetic makeup. There's yet to be anything that has demonstrated clinically meaningful benefit to influence egg quality, aside from those 2 parameters. The second is egg quantity, and this is really what we're aiming to target, is improving the number of eggs that a woman can harvest at any given point in time to improve her chances of having a successful outcome in IVF. And so how we would do that is introducing our recombinant AMH as a pre-treatment, as a neoadjuvant that would be offered before the stimulation. And what happens when you're suppressing the follicles with AMH as a pre-treatment is you're actually synchronizing the follicle development in the ovarian reserve, such that once you relieve that suppression, you take away the drug, there's a greater than typical wave, which you can see here. And actually, I'll toggle back and forth for the visual effect, which can be helpful. Oops, wrong way. There's a greater than typical wave that is able to be recruited and then stimulated by the stimulation drugs and then, of course, captured on the other side. And to that end, we have done preclinical experiments in rodents demonstrating that when you follow the protocol you saw on the previous screen, you can actually get 3.6x improvement in the number of oocytes captured through your standard ovarian stimulation protocol. And actually, if you recapitulate that protocol in rodent models of diminished ovarian reserve, you can double the number of oocytes captured and importantly have no negative impact on egg quality. These results have also been independently verified in an independent academic lab. In their hands, they saw not only improved oocyte number, but also improved egg quality. That is not something we'd put on the label, but I do think it's worth stating because we do know that it's one of the important toggles for successful outcomes here. And if there's a chance that AMH pretreatment improves egg quality, then that's something certainly that we want to monitor and be able to speak about based on the data. So I'll come back to this slide and close this talk really to say that we're at a really exciting juncture because I think people are increasingly recognizing the importance of the ovaries as being the heart of health and well-being for women, especially as they age and especially once we approach menopause, how their function directly and dramatically influences not only quality of life, but health and longevity. And while it is a long path ahead of us, there are very clear steps to take that allow us to move the needle and develop innovative therapeutics that we can offer to women, hopefully in what will be a suite of options to intervene on and modulate their own transitions through their reproductive life with more tools and resources at their hands. So this is where we are now. We are actively fundraising right now, so anyone in the audience who is in that space and wants to speak, I'd love to talk to you, so please find me afterwards. And I'll put my email on the next slide as well. And it's been a real pleasure sharing that story with you, and I'm looking forward to hearing some questions. Thank you.
Hi. Regarding the fundraising, the previous presenter had the same issue with the women's health raising funds versus a male billionaire's funding. It was very interesting that you could transplant ovaries from young mice to the older mice, and you didn't say if it really worked. The older mice can give birth and the ovary function correctly? If so, follow that up for your fundraising. If you can do the same for the male, I think you would get a big, big donations on the other side. And also one other thing I wanted to say is have you tested the microbiome of each ovaries? Because I've read a study about a few years back. With the microbiome, the transplant, they also had about 5 to 6% increase.
We are not focused on the microbiome, so we have not yet looked at that. With regard to the mouse experiment, there's a couple of different issues you bring up. And I think it goes back to Jennifer's earlier point that women exist beyond their baby-making capacity. And I will say, not that you're saying we should just be baby makers, but our goal is not to extend fertility for indefinite periods of time, and I have a child myself, and I would not want to be a pregnant 55-year-old woman. I barely want to be a pregnant 36-year-old woman. So our goal is not to extend how many years of life a woman can be pregnant. While that is a natural consequence of extending ovarian function, at least to the degree that the rest of the body is capable of safely housing an embryo. I think the bigger issue there is the egg quality and the genetic decline in the eggs that a woman has. So that's sort of a separate issue. So whether the experiment worked, I think it depends on what your goal is. Is your goal for a 70-year-old to have a baby, which I noticed in the news that actually just happened recently, which completely floored me. And again, is not the goal, but to someone who wants to do that, if your body can healthfully do that, go you. To each their own. We really want to offer therapeutic solutions that allow your maybe everyday woman, so to speak, somebody that doesn't want to endure the symptomology and erratic physiology that can come with perimenopause and menopause, and instead just maintain a consistent quality of life for a greater number of years. That's really more what I'm personally interested in and the goals of our company. So I'm sure that if this is successful in the way I've described, that will also influence the reproductive window for women, and certainly the intervention point at which we really introduce this into a healthy reproductive population will also likely influence how that changes the reproductive longevity aspect of the conversation. But again, I think you really have to think about what are your goals, and those are our goals and what we really aim to offer. Yeah, it's a great question. I think the short answer is it's hard to know without more data. But it also goes back to my earlier point of it's a little bit of how do you want to deploy this? Because we have my co-founder, David Pepin, had a really beautiful paper out in Nature Communications in June or July this year where they introduced recombinant AMH via gene therapy as a means of contraceptive in companion animals, so cats, that have been treated now for 5 years with no adverse events, and they have durable contraception in that model. So that's something I think is really interesting. So, I started oral contraceptives when I was, 18 or 19 years old, and I stayed on those for almost, 15, 18 years. I don't know exactly how long, but it would be really nice if I had an option to take a contraceptive during all of those years that also retained my ovarian reserve, as long as it was reversible. So it's going to come down to the modality and what the outcome is. I very much see this as something that could be used as a contraceptive in younger women. The main use would be contraceptive, but the sort of secondary benefit would be the ability to retain ovarian reserve, and then it kind of, for all the eggs that aren't deployed, they kind of go back in the bank to push that window out. We don't know that relationship. I'm sure it's not linear. If you take it for 5 years, does that give you 5 more years? Probably not, but it's hard to say without having better data. The other thing that I'll say is, in terms of intervention point, one place that I think that's really interesting is for women that either don't want to have children or women that have had all the children they want to have and feel complete with their family building, after which they could take a recombinant form of AMH or some modality of AMH that allows for contraceptive elements, but in a more permanent fashion that also just allows for that kind of retained ovarian reserve over a long period of time without the worry of, will this be able to toggle on and off and allow me to get pregnant later? So I think that's sort of the sweet spot, well enough before perimenopause that you get the benefits that it can provide to sort of either smooth out symptomology or reduce that and push out menopause, but after the fertility conversation is sort of already complete. I think, to me, that's sort of the earlier, safer version of it. Yeah.
Hi, thanks. That was really amazing. I'm Chiara from University of Innsbruck. I was wondering, have you or any other people looked into whether the AMH treatment also influences other hormones? Because that's obviously interesting. You already mentioned contraception, so we know that taking contraception for a long time reduces your risk of ovarian cancer, but increases breast cancer, so kind of modulating how we also influence cancer risk.
Yeah, it's really interesting. It's a little bit different in different organisms from what we've seen so far. In rodents, it seems to really suppress the cycle. However, in cats and in the primate data that we've generated so far, that's not quite the case. There's maybe some light suppression of estrogen, but the cycles that we are able to observe look normal otherwise, which is encouraging from that standpoint. You sort of maintain your normal homeostasis. Of course, you are potentially, let's say you push out menopause 5 years, you are getting those additional years of exposure, so it sort of becomes the same question of HRT of when is there an inversion of the risk-benefit ratio? And it might be that once we get to that point and obviously have a stronger data set, that there is a sort of clear cutoff of this is really great therapy for X number of years to provide you this sort of benefit, and then you might want to reevaluate after a set period of time, which is really how HRT is deployed currently. And I think that's a nice kind of base case that we could fall into easily, though I will say that with what we've observed so far, there's been no signals that there's anything problematic with how this would be sort of integrated into a normal physiology and the negative impacts that it could potentially have. It's so far looking really, really nice from that standpoint, so I'm encouraged by that.
Great.
Hi. Jennifer Lovejoy with Phenome Health. Terrific talk, really interesting. I was curious, kind of a basic question about AMH. I mean, as you're developing this product, and you mentioned a few things that influence AMH, the chemotherapy and PCOS, are there other things, like for example, if women take oral contraceptives for decades, as you mentioned, which is not uncommon, or some kind of hormonal contraceptive, does that impact AMH? Does it impact AMH in some? What about lifestyle variables, nutrition, exercise, and so forth? So what are some of the other things that influence AMH while we're waiting for your terrific recombinant drug?
Yeah, it's a great question. And if I'm honest, I don't think I know the breadth of the data well enough to answer that. Well enough to give that a great answer. I will say most of what we understand about AMH is really better understood at the population level than the individual level, so there's not a lot of strong correlations around, well, I'll also step back and say that AMH itself, it's a clinical biomarker. It's used in fertility clinics as sort of an approximate of the ovarian reserve, although you'll remember from one of the earlier slides, I don't need to go there, but it's produced from some of the sort of early maturing follicles. It's not actually representative of your ovarian reserve. So even how it's used clinically can be a little bit misleading for people. So it's a tough biomarker for that reason. I think there's a lot to be teased apart, and we are starting to put together a longitudinal study that will allow us to begin teasing that apart and answer some of those questions, because at present I don't think it's very clear. I will say that it does change over time. Whether hormonal contraceptives influence that, I'm not sure, but we do know that generally it obviously declines over time, and then you sort of hit a low threshold once you have a very small number of eggs left in your ovarian reserve, which is really what's triggering the ovarian decline that we experience as we approach menopause. I'm trying to think if there's anything else relevant from your question that could be helpful to say here. I mean, I think it's a fabulous question, and it's one that we think about and want to have a better answer to. I think is the bottom line, is that we need more answers around that, and it's certainly something we're working towards. And we'll probably have more answers to that before we have the drug in hand. So it will be something we'll feed out slowly in the nearer term.
We have one final question from a Zoom participant. The question is, would this treatment be geared more toward women who still have a lot of eggs in reserve but are having trouble recruiting them, as opposed to older women who have fewer eggs left?
Great question. I think it could be applied into either category. But there is, I think, as a woman gets older and has fewer eggs, it becomes mechanistically a little bit more difficult for that to be successful, because at the end of the day, if you don't have very much left in the bank, so to speak, for your eggs, then synchronizing them and recruiting out more still won't recruit a larger number of eggs, because you're just limited by that finite number that you have. So there is a certain cutoff point. You know, as we approach clinic, that will be somewhat guided by data, but we don't quite know what that should be. But there certainly is an upper age limit after which it's likely not to be meaningful for a certain population of women that just don't have much of an ovarian reserve remaining. Thanks for your questions, everybody. Thank you.